Okay.
Mhm.
Uh, Sarah is 7-year-old girl with features of Down syndrome. She is not cynos and not, sorry. You have to examine a 7-year-old child, examine the cardiovascular system.
Okay, fine. So who is keeping the time?
I will do, no problem. Just a minute.
No problem.
Start.
Okay. Hello,
Uh,
good morning.
Good morning.
I'm Dr. Hiren, one of the candidate here.
Yes.
Today I have been asked to examine Sarah. Name is Sarah.
Yeah, yeah, yeah. Yes.
Okay. Mom, is that okay if I listen to Sarah's heart and if I do examine her heart and pulse and also will look her eyes and the mouth? Is that okay with you?
Yes, yes, no problem.
Okay. So I'm just gelling my hand and I'm having a quick look whether there is any special surrounding, any oxygen uh, monitor, any cardiac monitor,
No,
any
nothing in this room.
devices. Okay.
Nothing
How
in this.
Sarah looks like any cyanosis or any she looks pink and comfortable at rest.
Yeah, she looks pink and comfortable at rest.
No distress, no cyanosis.
Not distress. Breathing
Right.
comfortably. No oxygen.
Okay, so Sarah, hello Sarah. You have a very nice hair, Sarah. What did you eat today in your breakfast?
Speech is little bit not like normal child. Like is
Okay,
bread, butter.
okay. So meanwhile, also I'm looking around whether there is any unusual dysmorphic features are there or not,
Okay.
like any features of the in the eyes, any
Mm-hmm.
hypotelorism or depressed nasal breathe or low set ear
Yes, there are features suggestive of Down syndrome.
features suggestive of Down. Okay. So now, uh, Sarah, I'm going to have a look at your hand. Can I have a feel of your hand, please? And we'll look for the pulse or
Mm-hmm.
any special character, any force, volume, tension.
Pulse.
How much the pulse?
Pulse is 90 per minute, bilateral equal. And
Oh,
anything else you want to know in hand?
no special character, right?
Like we can say palmer, single palmer crease and short stubby fingers.
Okay. And no peripheral cyanosis clubbing.
No, no.
Okay. And after that, I would like to check the blood pressure at the end of the examination. And now I'm going to look for in the eyes whether there is any uh, jaundice or any pallor.
No
Then,
jaundice, mild pallor.
okay, I'm looking the oral cavity for the dental hygiene and central cyanosis.
Dental hygiene is good, oral hygiene is good. No cyanosis.
Okay, all right. And after that, I'm looking to the neck, uh, whether there is any JVP or any lymph gland enlargement.
So, what position you will see in JVP? Like sitting? Okay.
Like in a 45-degree.
Okay. Okay. You're not asked her to lie down. Okay, no problem.
Okay, all right.
Uh, so, no neck glands noted.
Okay,
No distended one.
okay, okay. I will ask now, Mom. Mom, can you take off the shirt of Sarah?
Yes, okay. Done.
Oh, okay, I am just now looking on the chest whether there is any scar, visible scar, shape of the chest, any hyperdynamic precordium.
There is no hypodynamic recording. Shape is normal, but you notice a central mid sternum scar
Okay,
and scars of drains on the lateral side.
Okay, now I'm also looking on the both the axilla and also on the back, whether there is any scar in the axilla and on the back.
Okay, no scar in the back or axilla. You can say like lateral side there are chest drain scars.
Any visible pulsation.
No, no pulsations.
Okay, and also I'm going to have a um, now I will ask Sarah. Do you soar anywhere? I'm going to have a feel of your heart. I'm going to um, touch your heart just with my hand. If you feel any pain or any discomfort, please let me know. So I will stop.
Okay.
And we'll see whether there is any thrill present or not, and where is the location of the apex impulse.
Apex impulse is fourth intercostal space over the midclavicular line. No thrill.
Okay, and now I'm going to uh, also feel whether there is any palpable second heart sound is there or not. And after that, I will ask Sarah. Now I'm going to listen your heart. So I will auscultate at the four areas: mitral, tricuspid,
Mm-hmm.
aortic, and pulmonary. And I will listen for the heart sound as well as the headed sound, murmur.
Okay. There is a systolic
So
murmur heard all over, but loudest at the apex.
loudest at the apex. Now
No
there is
thrill.
no thrill, right?
Right.
No thrill. And is that murmur radiating to axilla on the
No.
back?
No.
No radiation. Okay. Also, we'll have a look of the meanwhile the whether there is any pulsation in the suprasternal area, and
Hmm.
also feel whether there is any thrill in the carotid and suprasternal area or not.
No. No.
Six
Murmur
complete.
related to axilla. Sorry.
Radiating to axilla.
Hmm.
Okay, okay. And also now after that, I will ask permission for examine the liver. Sarah, I'm just going to have a feel of your tummy. Is that okay? We'll just see for any cardiomegaly is there or not.
7 minutes done. No? 1 minute extra.
7 minutes done.
Yeah.
Okay. So
So
remaining like a pedal
you just
edema
complete
and the
the examination.
okay. So I will just listen in the back for any murmur in the back or any basal crepitation, and also look for the hepatomegaly to
Hmm.
rule out any evidence of the failure. And
Hmm.
we'll also feel for the pedal edema for any evidence of the congestive heart failure. So
Okay.
now I will present my case.
Hmm.
So I examine Sarah, who is 7 year old, lovely girl who looks. I sorry, I forgot to ask about the nutrition and build.
It's
Whether she
okay.
looks undernourished or well built. So I will say looks normal built for her age. However, I would like to plot her measures into appropriate centile chart. She has a feature suggestive of the trisomy 21. Um, on examination, her pulse is 90 per minute with no specific character. Her apex impulse is in the fourth intercostal space, left side midclavicular line. And there is a midline sternotomy scar and two small scar at the epigastric region. And her heart sounds and auscultations are normal. She has systolic murmur, best heard in the apex area, and which is also radiating to the axilla. There is no hepatomegaly and no pedal edema, no evidence of congestive heart failure. To complete my examination, I would like to check the forelimb saturation and forelimb blood pressure.
Mm-hmm.
So my impression here, putting all this finding together, uh, most likely Sarah has probably mitral regurgitation or residual VSD. The scar, midline sternostomy scar, consistent with probably with the repair of the VSD. And there's
Okay.
two small scar probably consistent with the drain post surgery.
Okay. Okay. So why the murmur radiating to axilla?
Uh, she's having a trisomy 21, so sometimes large VSD defect post repair there can be mitral regurgitation.
Yes.
MR lesion can murmur can radiate to the axilla.
Okay. So what advice you would like to give to the mother?
I would like to instruct the mother about like if she has any kind of weight loss or failure to try or any uh, cyanosis, she has to come to the hospital. She need to have a regular follow-up with the heart doctor, or also she need to have a regular echo to check the heart functions. As well as I would like to advise her to avoid tattooing and good dental hygiene. Yeah, good dental hygiene and needle piercing, tattooing.
Okay. Okay. Time's up. Regarding advice, like tattooing, you said a regular follow-up, nutrition, maintaining oral hygiene, and
Right.
vaccinations.
Yes, yes.
Okay. It was good. Most of the points were covered. This pulse like should be checked on both sides. You forgot regarding this built and nutrition initially.
Hmm.
Radiofemoral delay you did not ask
Yes, in
otherwise okay,
scar in the
but
femur.
maybe because of description it took little bit more time. If we do direct examination, then could be done little bit faster. Because of description, we
Mhm,
have to instruct and all. Maybe because of that, it took little more time. So
mhm,
summary was a little long, like almost 2 minutes. The summary, everything you covered, but a little faster you can do with
mm,
practice.
mhm.
It was good.
Right.
All points are covered. All points.
Okay. Anybody else for the
JVP
feedback?
actually, I think we should mention in the end. JVP.
Yes, you're right. I mentioned
Hmm.
unnecessarily.
The child was
No
sitting
need.
also, though we cannot take the JVP. Plus, when you inspect, then when you auscultate, that time you inspect the back. Not like during inspection you inspect the back, because like you have to turn the child here, there. Again, you have to take auscultate front. Then again you have to turn the child. That time also, and inspection time also, twice turning the child, moving. It's not like good approach.
Right, right.
And the
We can
trachea
mention.
palpation.
We can mention in the exam like I will inspect the back when I will auscultate the back.
Hmm.
That we can mention.
Yeah.
So
Yes,
That is,
Dr. Jay.
I was telling for the trachea during the palpation, the apex beat and this thrill and also this the murmur palpable and also the trachea palpation position of the trachea.
Uh-huh.
Is it important? Trachea
It's not
palpation.
no
important.
trachea,
Trachea
not
palpation is not
important here.
important.
Mm-hmm.
Just not, I did not mention for the palpation, but the thrill,
Mm-hmm.
uh, you have to, like, if you want to rule out the, aortic stenosis or pulmonary stenosis, you have to just see for the thrill, suprasternal thrill and carotid thrill, both. If you have a time, you can do it. Otherwise, it's not important in this case, actually.
Mm-hmm. And the second thing is once we find the murmur over the apex and it radiates to the axilla, or we suspect it is more of the mitral regurgitation origin. So we have to confirm by we have to ask the child to turn on the left lateral position, and also child have to expire to tell the on expiration and just hold the breath. So then it
That
will
is
be
mitral
more
stenosis.
not mitral regurgitation.
No.
For left lateral position to turn also.
What, Hiren? What do you say?
Mitral stenosis is more prominent. We need to ask for the left lateral position. But expiration, I agree. Any left-sided cardiac lesion will be prominent murmur on expiration. So no need to put the left lateral for regurgitation.
Okay.
But expiration, I agree, yes.
So,
Dr. Maila, anything from your side?
Hello.
Yes. Any feedback?
It was so perfect. But I want to ask one question. Here we have to palpate for heave or not. Left
Yes, yes,
burster
we have
dilatation?
to. We have to, yes.
Okay, and also for the dental caries, you have in any patient. I think in a cardiovascular, you have to just ask the patient, open your mouth. Want to check any central cyanosis, any pallor, any dental caries, like that.
Yes. Yes.
And if you want to just save your time, just so today I examined Sarah. She's 7 years old. She looks whatever she looks normal, average for her age. But I want to plot her on a growth chart appropriate for her age and sex. Okay, she has the features of Down syndrome. She has blah 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 blah. Going with whatever it's a complex heart disease, operated. Okay, if she has mitral stenosis, whatever you want. And I want to complete my examination doing forelimb blood pressure, like Dr. Heron said, forelimb blood pressure, pulse oximetry, and GVP. And palpate for the liver, okay? If you didn't do it, palpate for the liver. And the lower limb to exclude edema.
Yes.
During pulse examination, we have to also demonstrate for the water ML pulse.
If you are suspecting, yes. Otherwise, no. So
if the pulse is
here
like high volume pulse, then you can. Otherwise, if the pulse is not high volume, then not required.
Okay.
Sorry, I didn't get the point. Can you repeat? Sorry.
He said for the pulse, we have to demonstrate water hammer pulse. Right, but if the pulse is not high volume, this is not required.
Yeah, you have to just in the new system of the exam, I will just tell the examiner, I will examine the hand searching for what. Okay, I will examine the arm searching for what. Here we have to just check the pulse rate. Is it equal, bilateral, regular, and the character, the volume, the character of the pulse.
Right.
If it's if there is water hammer pulse, the examiner will tell you there is a water hammer pulse. So your mind will be directed to this. This is maybe aortic regurg or PDA, whatever. In volume overload.
yes.
Okay, so we will do finish communication. Okay, or
Yeah, we can do the remaining communication.
Okay.
Yes.
So page number. What was the page number? This
172 or
160, 122. So Dr. J, are you ready? You didn't keep
I-
date.
I will
Yes.
put the time. Okay.
So doctor name is Ahmed. Okay. So you have to talk to a colleague. At the colleague name is Ahmed, who is not filling the discharge cards. Okay.
Sorry? Hello.
Hello,
Yes. Colleague name is
Ahmed.
Hemant. Okay. Okay.
Ready?
Ready.
Yes. Start.
Good evening, Hemant. How are you?
Yeah, doctor. I am fine, doctor. Thank you for asking.
Uh, I know you might be knowing me. So I was wondering to have a cup of coffee with you and to discuss certain important issue of the regarding the teamwork spirit. So is
Yes,
it
doctor. No
okay?
problem. What issues you want to discuss?
Yes, Hemant. Most important nowadays in this recent, it has been brought into the notice by our team that you are not preparing this discharge summary. You're not filling in the proper time.
Yeah,
So
doctor. Who
this
told
real
you? I am doing my work. You can see I am so busy. I am working hard. I am trying to manage the patients. You know the shifts are so busy nowadays.
I understand, Eman. Nowadays it is going to be busy, but no one has specifically pointed out. It is our whole team which is involved. They have noticed. It is not only one doctor I specify. So many of our this team they have pointed out that you are not filling this discharge summary, and it
Doc-
has really it leads to this backlog and it increases the work of burden.
Uh, but doctor, like, what is important? Managing the patient or filling the discharge summary? I think managing the patient is more important than filling the discharge summary, isn't it?
Okay, but what do you think about the discharge summary? Are they important? I think they are equally important. Can you tell me the importance of the discharge summary?
Yeah,
What
you
is this?
see, but
Yes,
doctor, if everything is written in the file, why the discharge summary is required?
yes.
Everything is written
Let
in the file. Or if anybody wants, they can refer back to the file, no?
oh yes, but let me tell you, discharge summary it is an important. It is the mode of the communication between the secondary care and the primary care. It is written in the file. You are right, but once the patient gets discharged, then it discharge summary is nothing actually. It reflects the sequence of the events, isn't?
Yes, yes, doctor, right. But nowadays I'm busy. So can you please ask the other people to fill the discharge summary? Because if you feel that it's so important, then let others also do their part.
What is any other thing? Any that bothers you apart from busy? Is there anything that you face difficulty in making discharge summary?
No, no, not feeling, but I'm not getting time enough actually. So other
Okay.
people can fill the discharge summaries. Because I am doing most of the work, so is there any problem for them to fill the discharge summaries?
Right, I agree with you. But since you see, this is again the as per this hospital value, this the work is distributed as per the hierarchy, right from this consultation from the senior colleague and the junior. Everyone has. We should undertake our responsibility, whatever work we have assigned, to run our this teamwork smoothly in the best interest of the patient. Is it okay?
Yes, okay, doctor, but like so much backlog is pending. So, I will start filling here onwards. Let the past discharge summaries like that only.
Okay, can you enumerate me any other the apart from this patient's information as you told, or whatever the events, any other the benefits of the discharge summary? Why discharge summary is important?
The importance is like it's a summary, so we can refer quickly. If the patient comes in emergency, we can refer quickly. That is what I feel.
Okay, but it is most important in this, Hemant, I tell you, in this post health hospital care, and also the GP would be able to know whatever happened during admission and also for the future follow-up. And apart from that, I can also tell you it is most important also for the efficient teamwork, as you rightly pointed out the backlog. So if we, every one of us, which what everyone, our objective is we should perform our own work, so that would then it will reduces the burden if we will fill it in the due course of time.
But what will happen, doctor, if I refuse to fill the discharge summary?
See, discharge summary, yes, this your valid question. If you are not, then it will again increases this the workload, and again it will be reflected. This will disrupts our the harmony between our colleagues, and again the workload increases, and this subsequently this will also reflects your reputation.
Okay. But doctor, how to handle this backlog? Can you guide me? Or can you help
Yes,
me in filling the discharge summaries?
yes, we will sit together, and whatever the problem, as far you told this time management, and so we will discuss and we will help
6
out.
minutes. 6 minutes.
Yes, yes. Okay, Aman.
Okay, okay, doctor. Uh,
Hmm.
But can you help me in filling the discharge summaries?
Oh, yes, but I will try to start out this by making you the at ease, and whatever the particular this problem you are facing, so we will facilitate you. But you should keep in mind it is an important document apart from this managing the patient.
Okay, okay. Thank you, doctor.
So can you tell me what we have discussed today?
So we have discussed the that importance of discharge summary, why it is important, and it is important to maintain the department harmony. If I don't feel, then it will affect my reputation. Yes.
Okay, thank you, Hemant, for listening me. If you have any query and concern, and you can reach out to me at any time.
Okay. Thank you, doctor. Thank you.
Okay.
Okay. Finished.
Still time
Okay.
is still there.
Okay. Okay, Doctor Jayaprakash, you did well.
Mhm.
Few things like you did not tell your name. You did not introduce yourself.
Mhm. Deliberately, I thought that you might be knowing, so I
Don't
we have.
assume things, no.
Mhm.
We should not
Okay.
assume. Okay.
Okay. We have.
Secondly, role player concerns has to be addressed. Not like we
Mhm.
are here to discuss the things which we want. That is there
Mhm.
that we want to uh, tell what we want, but what his concern is also for he's saying like what will happen if I don't fill discharge summary.
Mhm.
Then like there like we have to threaten them, like if you don't fill the summary, the word may go to the consultant, then
Mhm.
consultant may take certain actions and it will affect your education. He may inform you to your education supervisor also.
Mhm.
Okay. Then like when I asked like what is the importance of discharge summary, why others cannot feel from for me, there you
Mhm.
answered correctly, but I have to ask that two times. First time I asked, you said, do you have any problem in your personal life? Like
Mhm.
I was saying something, you were saying something. So role player, listening to role player is very important. Again, will you help me for discharge summary? So what will you answer?
This is a really I could not able. You
Yeah,
just tell me.
if you promise me to fill the new discharge summary regularly, I can help you to clear the backlog. But you have to promise that you will not keep the work pending.
Mhm.
Okay. Then next
Okay.
question will come that will you tell the consultant? They're also same. If you
Hmm.
promise that you will fill the discharge summary properly here onwards, then I will not tell consultant
Mhm.
like this.
Yes, Dr. Hiren. Any other point?
Yeah, actually, yes, you did good. You asked the concern, and regarding like when he asked whether you will help, yes, you have to help whenever you know. If role player is asking, you can mention in a nice way, like yes, you have to promise that you will
Mhm.
finish the remaining, and then I will also help if you need my help.
Mhm.
Then also you have to, like you mentioned, actually it is important document,
Mhm.
but you have to reflect in a nice way, like this document goes to the GP,
Mhm.
and it is also part of the medical record. It goes to sometime to the
Mhm.
insurance companies or for the legal purpose to
Mhm.
revoke the record whenever a later point of time if it is required.
Mhm.
So this is a very important document or a piece of a paper
Mhm.
which which usually goes to like all the healthcare provider wherever the patient visits,
Mhm.
so they have a easy access for the whatever the condition he suffered, or like in a one line or two line you can mention that. Otherwise goes good.
Yeah, one Dr. Adib's meeting I heard, they also we have to specify as far the importance is concerned. We have to tell from the financial aspect point of view that there are certain
Yes,
commission group, and that is reimbursement is made on the basis of the discharge summary, whatever the procedure or whatever the expenses incurred. So
yeah,
that in that way our trust will be benefited from monitoring point of view.
yes.
So we
And
are
then
left with 3 minutes. We'll take Dr. Maila's opinion.
yes, yes, Dr. Maila, yes.
Yeah, I want to ask if in a difficult with a difficult colleague, I have to ask him to sum up because it's not an education. It's a very bad situation, and I
Yeah,
just
yeah, yeah. Right.
advise him.
We
Yeah,
have
Hmm.
to summarize.
yeah. No, it isn't suitable here to ask him to sum up what
Right.
we've discussed
Very,
today.
very correct. I forgot to actually mention this point. Very
Hmm.
Yeah,
correct.
and
Yes.
also, Doctor, I think Doctor Sandeep is the one who was the role player.
Yes.
Yes.
Yeah, the role player was so decent.
So,
Difficult colleague, so decent,
Yeah.
so decent and so kind. Difficult colleague, it's a stubborn one, okay, and he will insist I'm right and the others are wrong until you just tell him I'm so sorry. If you just don't want to follow the rules here and our system, I have to inform our consultant by that. At that point, he will just take a step back and he will tell you, so what do you advise me? So if he insisting, still insist, I will tell the consultant, I'm so sorry for that. I will tell the consultant because that will affect our system and our care for the patient. This is the clinical governance. It's a part of the clinical governance, okay, to
right.
just care for the patient, yeah. And that document will uh, just save you and save the patient. Also, if you just didn't feel it, okay, day by day or after the patient discharge, it will affect your performance and your report. This is it's a part of from any educational supervisor. This is a point that will affect your grade at the end of the training or whatever. So this document not important not for your patient but also for your performance assessment.
Yes, correct. Yes. So very good discussion today. So,
Yeah,
Thank
good
you.
point.
Thank you.
I'll post the recording also, and we'll meet next 3-4 days later. Okay, I'll post in the group.
Thank you.
Thank you. Thank you.
Thank you, Dr.
Okay.
Maila, for joining. Very nice inputs.
Yeah.
Uh,
And nice
Dr.
to
Sandeep,
train with you. Thank you. Thank you to make me practice with you. Thank you.
Yeah,
Dr.
please join
Sandeep,
regularly and enlighten us. Huh?
should we ask for the any problem at home or work like that?